Today, I'm going to talk about research to drive improvements in care for cardiovascular patients, and just a little some disclosures here. For some of you who don't know this, I joined PCORI about a year ago, and prior to that, I spent about 20 years at Duke, where I was a practicing cardiologist and researcher. And a lot of the work that I did was mostly, and I'll show you some of the work that I did back then along with my colleagues and mentees. But a lot of the work that I was doing was in part funded by the government, and a lot of this was also in part funded by industry. So you'll see some of the disclosures there. None of these relationships are currently active for me. So I think we can all agree that cardiovascular outcomes still has a lot of room for improvement. If you look at death attributed to cardiovascular disease, these are the AHA stroke statistic, stroke and death, the heart and stroke statistics. You'll see that even though we seem to have made a dent in death attributed to cardiovascular causes, in recent years they've kind of taken a really concerning uptick in worse outcomes. And so there's definitely room for more improvement here. And what I'll spend some time talking a little bit about today is how we could potentially think about leveraging the data that we have at our fingertips to better deploy healthcare resources. And then to think about how we can work on research that really tries to identify what's preventing patients as well as clinicians from practicing what we think is best medicine. And then I can't be coming from PCORI and not talk about patients. So I'm going to spend the last part of the talk really talking about how we can identify opportunities to better engage patients, not only in their health management, but also in the research domain as well. So that beautiful mug you see out there, this is of course our lovely Fatima Rodriguez. And I think she and I worked together on the AHA COVID registry, and one of the key messages that we see from many of the clinical research projects that we do is that health disparities are everywhere. And achieving health equity really needs to be one of our key priorities as we think about clinical research here. This was work we did on the COVID registry that basically showed during the pandemic, the types of patients who were coming into the hospital were way out of proportion to what we were seeing in census population descriptions here. And correspondingly, the mortality was also being borne mostly by patients who are typically underrepresented in clinical research. This was work done by Dr. Essien. As you can see here, some of you might know him. He's very engaged in health disparities research as well. And this is some of his work that he did that really focused on social determinants of health and how these come into play with the concept of pharmacoequity. There are some, these social determinants of health often prevent folks from being able to access or afford the types of therapies that we think should be very evidence-based, equally used, equitably used therapies. And this was AFib. This was a population of patients with AFib looking at anticoagulant use. We know that there are also systems-based outcomes differences, and this was some very nice work done by Dr. Amit Vora, who was a former mentee of mine as well, who really looked at hospitals like Duke, like Stanford, that often take in transferred patients. So these are patients that often come to a more community practice type hospital and that get transferred here for tertiary or quaternary care, and looked at readmission rates afterwards and showed that there was a significantly higher risk of cardiovascular readmission in patients who were transferred in versus those that came directly to our hospitals. And this is using the National Cardiovascular Data Registry, a very large nationwide registry that's looking at ACS patients across the entire country. So this can be really attributed to more system level types of differences, whereas before we were talking about perhaps more patient level differences. if you think about medications, one of the key things is medication adherence. On the slide are 5 classes of therapies that I always jokingly refer to as the 5 vitamins after a post-MI hospitalization. And these are therapies that everyone should leave the hospital with, and they usually do because that's a requirement. It's something a lot of guidelines look at. But as we look at things as even as short-term as 90 days after discharge, we're seeing pretty large variations in how patients are adherent to these vitamins, if you will. Particularly true for things like statin therapy. You'll see that that's the green curve all the way at the left side of the curve here. Perhaps a little less so for P2Y12s that tend to be, post-stent requirements. One of the things that we often talk to patients very directly about: do not stop taking your clopidogrel or your prasugrel or your your ticagrelor. So that's something that we pay very much attention to at discharge. This was very nice work that was done by Kamal Faridi, who was a med student at the time when he did this work with us, that started to look at how we can change some of these patterns, particularly adherence. And one of the things he did was to just say, well, what about when's their first follow-up appointment? Does that make a difference? Now, all of this is observational, so no causal inference here. But it was very interesting here because, we had these requirements at that time that every patient needed to have a follow-up appointment within 1 week after discharge, and we broke our backs trying to get that scheduled. But it turns out 1 week, 2 weeks, even 4 weeks, not much difference in the relationship between that and things like adherence. But if you wait longer than 6 weeks, perhaps you've just lost that window of opportunity to intervene. And so this provided us a little bit of reassurance in terms of, okay, maybe we don't really have to go crazy trying to schedule that patient for that first week post-discharge. Maybe we've got a little bit of leeway. Or there might be other patterns of being able to provide that kind of care. And this is really amazing work done by one of our interventionalists. I keep saying our when I refer to Duke, even though I've been away from Duke for more than a year. But Jen Reimer, who's one of our incredible interventionalists at Duke, who really started looking at how we use advanced practice provider types of resources. Do you guys use APPs? And I'm sure everyone does. That was my assumption then too, is that everyone used APPs to help do these kinds of cardiovascular follow-up. And again, we looked at national data. If you just look at those numbers at the top, you'll find that that's actually kind of rare across most practices. There are only about 3,000 with an APP visit, whereas there are about 26,000 with a physician-only visit. So this was really a way for us to be able to look at how we were leveraging these APP resources. And our hypothesis back then was, okay, so you discharge a patient from the hospital. Hopefully the more complex ones will go see a physician. And perhaps the more routine bread and butter types of patients might go to an APP for follow-up. And that's exactly the opposite of what we found in our data. We found that APPs were seeing the sicker patients, they were seeing the older patients, they were seeing the patients with more in-hospital complications. And probably the reason for that is because it's really hard to schedule with a physician sometimes. It's sometimes a little easier to schedule with an APP. But it certainly doesn't quite make sense if we were thinking, okay, physicians perhaps can deal with more complexity and APPs can do a lot of the more sort of health maintenance types of things. That's really not what we're seeing here. We are seeing that even though the APPs are seeing more complex patients, they're actually still using evidence-based medications at about the same rate as physicians are, which I think shows the value of leveraging APP resources in these post-MI patients, because often the sicker patients are the ones who are less able to adhere to guideline therapies. So this gave us some insight about how we can really think about shifting how we deploy these types of resources. Now, if we're wanting to talk about medication adherence, no one can avoid the sort of elephant in the room, which is cost. okay? Patients aren't gonna fill medications if they don't have the money to fill them. And back when I was practicing a bit more frequently, you know, P2Y12s were one of the hardest things for people to be adherent to because of cost. You know, this was done in the days where clopidogrel was the only generic that was available. Ticagrelor and prasugrel were non-generic and usually involved at least a $30 copay if you had insurance. And if you didn't have insurance, often you had to figure out how to afford these types of medications. Yeah, at the same time, guidelines, jumping forward too much there. At the same time, guidelines were telling us we should be using prasugrel or ticagrelor, or these higher potency P2Y12s in certain patients, because these were therapies that in, you know, your phase 3 trials, phase 4 studies were showing significant even mortality benefit, but definitely cardiovascular benefit. So a lot of our hands as physicians was really tied because we could really only prescribe things that the patient could afford, or things that we knew that not only could they afford the first time, they could afford it for the next 12 months, because that's generally sort of the recommendation for how long to use these types of therapies. So we were pretty darn lucky, I have to say, to get an industry sponsor to sponsor a study that was really focused on adherence. And what we did in this case was we randomized hospitals. We had about 300 hospitals, and we randomized them into one of two groups. One group, both groups could prescribe whatever they wanted, clopidogrel, prasugrel, whatever, okay? One group was usual care, and the other group, whatever the physician chose to prescribe, we would offset that copayment for the patient. And our hypothesis was that if we did that, then we would untie the physician's hands, and physicians would be able to prescribe what they thought was the right thing for the patient to take. And then we would also untie the patient's hands, and they'd be able to stick with their P2Y12 therapy for about a year, which is what guidelines have recommended at that time. Okay. So that was sort of the setting for the experiment here. So what do we see here? Well, in terms of untying the physician's hands, yes, we helped a little bit. So on the right-hand side, you see the usual care arm, and on the left-hand side, you see the intervention arm. And so we did see that there was a lot more transition to a higher potency P2Y12. Now, it's not 100%, and we didn't expect it to be 100%. Not everyone can tolerate a high potency P2Y12. Moving forward, not everyone can tolerate a higher potency P2Y12, but it did help in being able to do that, and it did sort of reduce the likelihood of us as physicians picking clopidogrel. What did it do with 1 year adherence? And we measured adherence in 3 different ways, mostly because there were some ways that was very convenient to assess adherence, which is basically calling the patient up and saying, what's your adherence been like? Which we know could be a little fraught sometimes with bias. We also looked at pharmacy fills to see how often they were actually picking those drugs up, which again has some bias. We also sent people to patients' homes, rang the doorbell and said, hey, I'm here to draw some blood from you to see if you've got some drug in your system. Arguably, a little bit more objective, but we can't possibly do that for every single patient out there. It just doesn't quite work here. But it didn't matter. No matter how you looked at adherence, it consistently showed that we were able to get patients more to more likely continue their therapies out to 1 year, which is what guidelines were recommending. So this was precisely the type of effect that we were hoping to see, is that we would untie physicians' hands and we would untie patients' hands as well. We also saw that the effect actually extended beyond P2Y12. So P2Y12s were at that time arguably the most expensive class of medication people had to take. Everything else, the other 4 vitamins, as I used to call them, beta blockers, statins, ACE inhibitors, they were generic. Okay. But what we also saw was that we had this sort of spillover effect. Even though we only paid or helped the patients defray the copay of the P2Y12, we were seeing a boost in adherence in all their other medications as well, except maybe ACE inhibitors that crossed the line of unity. But that was kind of interesting. And we explored this a number of ways. Did we reduce their financial hardship enough that that effect spilled over to their other therapies? Or did we help patients not have to skip a fill just to try to deal with the cost issue? And all of those kind of panned out to a certain extent. So what do we currently do now? This was a survey that we did at the beginning of the study, where we asked hospitals, if someone told you that they couldn't afford their P2Y12 inhibitor, what would you do? And this is what hospitals said that they could do. And I'm sorry, there's a typo here. The red bars, they do nothing. They can't provide any sort of vouchers at all. The greens, the 18% and the 31% were ways where hospitals could provide some form of assistance, usually hospital-sponsored, but sometimes often using pharma resources to be able to do something like that. After the study, we asked the same question a year later to say, what's going on at the end of the study? Did the study change people's minds or people's practices about what they did? And it was very interesting because the 51% of hospitals that weren't doing anything before, they had somehow, half of them had converted to providing assistance at the end of the trial. So it did seem to make a difference to the health systems that we were able to do this kind of study. Our third hypothesis was, if we removed the barriers to prescribing the medication, and we removed the barriers to patients filling the medication, then hopefully patients should do better. We should see better clinical outcomes, right? Because we want some nice, hard clinical endpoint when we're doing these trials. This is where we're SOL, because we really saw no difference in clinical outcomes between the intervention group and the usual care group. And this is where we were, we scratched our heads a little bit. So we were like, why is that? And in part, I think because perhaps we made a dent in both of those, but we didn't make a huge change in both of those. But here's probably the reason, which is surprisingly, 28% of the patients who got a voucher actually chose not to use it. Now, psychologically, I don't understand that. You give me a coupon, even if I don't need that stuff, I'm going to use the coupon. But apparently, my psychology is off base, and 28% of the population basically said, hey, even if you give us a coupon, doesn't necessarily motivate me to go and pick up this medication. And so, this was a post-hoc analysis, but now if you take those outcome curves and you look at, you split them into two, the yellow and the green lines that are on the slide here, you see that the patients who actually use the voucher perhaps seem to benefit from it. But the patients who did not use the voucher, that yellow line up top, there's something about those patients that was probably driving their behavior not to fill the medication, but also driving their outcomes towards sort of the worst side of things. And so what do we take away from this? Throwing money at things isn't necessarily going to fix the problem. You still have to think about the whole patient. And so, what do we do with this? Well, this is Alex Vanaroff. He's one of the interventionists at UPenn now, again, a former mentee of mine. He basically started by creating a model to see who would actually use a voucher versus not, and it depended on a number of things, including whether or not this was a generic drug versus a non-generic drug, and many of the sort of financial factors associated with this, in addition to sort of clinical and other social determinants here. And what he found was that, if patients who are at high likelihood of using the voucher, they were definitely more likely to benefit from it, whereas the ones who were less likely to use the voucher would less likely be able to benefit from this. So in part, this model helped us to say, okay, perhaps we can use this to predict which patients might benefit from these sort of financial resources. because we don't have a whole pot of money that's ready to use. We've got to sort of use this pot pretty rationally. And so these are patients who might be more likely to benefit from these sort of financial assistance tools, whereas the patients who are less likely to benefit or less likely to use these type of financial benefit tools, we need to be thinking about other things to be able to do for these patients. All right, I'm gonna skip to something else completely different, because so far I've been talking about throwing resources at a problem. Let's talk about de-implementation, taking resources away. ICUs, okay. So I trained at the Brigham with Eldrin, and I loved my time at the Brigham, mostly because back when I was training there, some patients went to the CCU, some MI patients went to the CCU, other MI patients, they did fine, they went to the floor. I felt bad for our attendings because they were the ones triaging this all the time. But when I came to Duke, and this was a long time ago, 2 decades ago, I was really, really surprised because Duke was really all the way on the other end of the spectrum. Almost 100% of our MI patients, regardless of whether or not they were stable or unstable, they all went to the CCU. And so Alex and I looked at this to see, what the national patterns were. And this is sort of the spread across, I think this was about 300 or so hospitals. Yeah, 300 or so hospitals across the US using NCDR data. And so the left-hand side are the hospitals that were really more selectively admitting their patients to the ICU. Then there was an intermediate, which is sort of the bulk of the hospitals. And then, as I said, Duke at that time was sort of an outlier. We were on the high end where more than 70% of our patients were admitted. And in fact, probably more than 90% of patients were admitted to the ICU. So there's definitely that spread across the country here. We thought that hospitals who were more selective about bringing their patients into the ICU probably assess this based on clinical severity. So they would bring the sicker patients into the ICU, whereas the less sick patients they would send to the ward. But it turned out, if you created sort of a risk score, this was the mortality risk score, that there really was no difference. So perhaps what was driving this reason was really more some sort of practice-based preference here. During the daytime, you might be fine going to the ward. During the nighttime, you might go to a CCU. Or which ED attending happened to be on service that night, or which cardiology attending happened to be on. So there wasn't quite that clinical stratification that said this is, regardless of whether or not you're a high ICU utilizer or a low ICU utilizer, that said this is a patient that needed to go to the ICU. And we would ask people, how do you know someone needs an ICU? Obviously, if they're in cardiogenic shock, if had a cardiac arrest, these are patients that should go to the ICU. If they're intubated, they need to go to the ICU. If they're hypotensive, they need to go to the ICU. But if you look at a population of patients who are not cardiogenic shock, not cardiac arrest, hemodynamically stable, how do you tell which patients might have a higher risk of requiring ICU type of support versus not? And so that's what we did. We created something called the ACTION ICU risk score. ACTION because it was derived from what was called ACTION registry at that time, part of the NCDR. And we basically looked at these patients who were relatively hemodynamically stable at admission and tried to see which one of these patients would eventually develop an adverse outcome that might require ICU level of care. Okay. And so that risk score developed, sort of this is how you distribute the scores. And we thought no hospital would be the same in terms of where they're going to establish their threshold, because there are some hospitals that have great rapid response teams, or some hospitals that have a glut of ICU beds, or some hospitals that have almost no ICU beds. And so they might sort of figure out their threshold for triaging depending on their own sort of level of resourcing and comfort with triaging these patients. So we would say, a hospital could use the score and figure out this is the cut point. for which we would send someone to an ICU, and this is a cut point for which we would send someone to a floor. Again, recognizing these are patients who are stable at the time of admission, so nothing bad's happened yet, okay? And, going beyond sort of publishing this risk score, you never publish something unless you feel you can stand behind it. So I asked Alex, can you stand behind it? He said, yes. I'm like, okay, you want to implement it at our hospital? And he said, yes. So he worked with the EPIC team, which, as you know, is a pain in the ass to do. But he was able to get this risk score embedded into our EMS. It was kind of nice in that a lot of the variables from the risk score could be pulled from the electronic health record and auto-populated. It was kind of inconvenient in that there were some things not pullable that required a clinician to input in there. And so, there are some things that you could do that's really doable, and there are some things that you couldn't do that, someone had to either click yes, no, or do something with. And it would spit out a score for you. And then based on the score, it would sort of make some recommendations of how high risk or low risk. Now at Duke around this time, and still the case here, the CCU fellow was the person who sort of bore the brunt of these triaging decisions. 24 hours a day, probably about 24 calls a day from the ER saying, we would like to send this patient, this MI patient who's totally fine, up to your CCU. And so this was one of those things where it also involved a cultural change. We needed to be able to say to the ED physicians, you know what, the score's 2. This patient's going to be fine. Why don't you just send this patient to a cardiology floor? Or the score is 5, and there's something off about this patient. You're empowered to call the cardiology fellow to sort of get a bed for this person. But it was a way to try to make things reduce the call volume for the CCU fellow, which is always a good thing because they're running around doing all sorts of other things. But it was also a way to really try to deploy our resources in a way that kind of made sense based on exactly how we predict these patients would be done. And it was also a way for us to de-implement in that we did not need ICU beds for all of these pseudo-stable patients. Okay. So I spent sort of the first part of the hour really talking about leveraging data. And now I'm going to spend the rest of the talk really talking about how do we engage patients. Okay. Why do we need to engage patients? Because we think differently from patients. This was amazing work that Anne-Marie Navarre did. She's now a prevention cardiologist at UT Southwestern. Where we kind of looked at, this was around the time when the pooled cohort equation came out. And this was something that allowed us to more objectively quantify ASCVD risk in our patients. And what we did was we looked at the correlation of our, quote, objective assessment of patient risk versus what patients self-reported their risk was going to be. And as you can see by that scatter plot up there, there is no correlation. Okay, so we're not starting from the same page. We're coming from totally different areas. We think something, they might think something completely different, and they might be right. Who knows? There was definitely some difference depending on what kind of ASCVD patient they were, but it also meant that there were, because of this sort of misalignment in risk expectation, there was also differences in willingness to consider things like statin therapy, for example, for prevention. So a key part of this is now being able to communicate with patients about what we think or what we calculate their risk could be. And there are many, many ways of being able to describe risk. And in the shared decision-making era that has been the case for the last several years, you've seen many of these happy, frowny face plots going on, where we feel like this might be a very effective way of saying, hey, it's green, it's a good thing. If it's red, it's a frowny face, it's gotta be a bad thing. maybe this is a way to help people with limited numeracy or health literacy to be able to think about their risk. So what we did was a couple things. First, talking about concept. So the pooled cohort equation really gave us 10-year risk prediction. The Europeans don't like using that. They like looking at the risk of dying from cardiovascular disease. So there's death risk. There are other groups that really prefer looking at lifetime risk, and obviously it depends on what age the patient is. But what we did was we deployed the study, and I know this sounds really silly, but this was about 10 years ago, in a really cool way with an iPad. Did that sound convincing at all? It was really cool back then. But anyway, so we deployed this on an iPad. But what we could do was we could randomize on the iPad which format we communicated to the patient. And so patients were randomized between how we explain, what kind of risk time frame we use, or what kind of death versus ASCVD risk time frame type of concept we use, to really show that in terms of communicating how high their risk was on the left, or in terms of their willingness to start statin therapy on the right, that there are some differences in terms of how well we can, how effective we might be in motivating someone to adhere to what we perceive are strong preventions or recommendations depending on the risk. So on the left, lifetime risk seemed to be the most convincing to patients about their self-perception of risk. On the right, this might translate a little bit to their willingness to start a statin therapy if they weren't on one before. How about those smiley faces? We'll call them pictograms. Now, smiley faces, honestly, for me, does nothing. It's annoying. It's really annoying. I look at that and I'm kind of like, grr, it's dumbing things down so badly. I like bar graphs. I like bar graphs with an arrow that says you're going from this to this. And then there are people who just say there's, no graphics, just tell me in words what it is. So we randomized this. We randomized this with our cool iPad. And basically looked at different ways of showing this that seemed to show that the pictograms did nothing for people either. I'm right. And that the bar graphs were effective, but no more effective than just using words alone. So I think this has sort of shaped, at least, or made me a little bit more cynical about how physicians feel that they know how to communicate, and that this is a way that we know patients would be more receptive to information. I think we need to actually work with patients to be able to do that. And of course, it's true for many of the other things, not just about communicating risk. This was a study that we did, Jen Reimer and I did, with a number of patient advocates. You might recognize some of the faces up there, Melanie and Deb. These are very, very strong proponents of, very strong patient advocates for atrial fibrillation. And we did a survey that we co-designed with them to really sort of contrast different perceptions of AFib risk and what motivates people to make decisions, whether or not, a DOAC with its fixed dosing was comforting or comfortable for the patients. And you do see that while there are some areas where we are very, very well aligned, like, yes, it's important to take a medication if it reduces the risk of stroke. There are also some surprises for us as clinicians as we think about things that we think are important for patients that patients don't feel exactly the same. So patients actually like the idea that you can titrate a dose, which is the whole reason why we moved away from warfarin, because we think, oh, they must hate that. But they like the fact that they can sort of titrate that dose. So I think it's important to think, as an example of, we really do need to hear what questions we want to ask or what strategies we want to design based on patient input. This was a study that I was very, very partial to, and it was a study that was run out of Cleveland Clinic. Luke Laughlin presented this study in a couple years ago. And it was one of my favorite studies because in clinic, and you've probably dealt with this quite a bit too, we've got tons of patients who say, I don't want to take a statin. I want to take garlic. Or I want to take, fish oil or turmeric or red yeast rice extract and all these things. And, this was a very simple study that was basically taking all these things that patients would prefer to take and looked at with their purported cholesterol lowering capabilities, and actually did the study, a very simple study, that just looked at the percent change in LDL. And it was compared with a placebo, and it was compared to 5 milligrams of rosuvastatin, okay? The sort of arguably one of the smallest doses you can really give to someone with relatively few side effects. And we just looked at this. And this is a graphic I ended up printing out on a card and laminating it and putting it into my pocket, because anytime someone said, I'd really like garlic, I'm like, look, garlic raises your cholesterol. Don't do that. So again, this is something where I think the question was really entirely driven by what patients tell us. We do the study, and now we can use that information to really help educate and communicate about things. This is also one of my favorite trials that I did right before I left Duke to go to PCORI, and I actually thought that the study would not be able to, that this was a study I would need to hand off to someone when I left Duke. But unfortunately, 2 weeks before I finished at Duke, the DSMB terminated the study due to concerns. And so I spent the first 3 months of my time at PCORI trying to wrap up loose ends on this study. I'm still very proud of this study. And we've all had patients who are sort of in their 50s or 60s, youngish patients who've had a mechanical valve and are, bought into warfarin for the rest of their lives. And starting from my early days at Duke, I had a cardiology hematology attending, Rick Becker, who we would have, tea, and we'd talk about, gosh, can we really figure out how we can get people away from the need for warfarin, for the need for lifelong warfarin. And so when this trial opportunity came around, it was one that was really amazing. So this was looking at a particular type of mechanical aortic valve and then randomizing to warfarin versus apixaban. And we went through a lot of steps to try to get to this dose of apixaban. We also went through a lot of steps with patients to figure out, to make sure that they would be comfortable with being randomized to apixaban, because, warfarin was the gold standard, the only thing recommended. And there were concerns from a regulatory standpoint about whether or not we had equipoise to randomize to something else. So this was a smallish trial, 1,000 patients. We wanted to hedge our bets a little bit and wait 3 months after implantation before we randomized them. And then we randomized them, and we had some discussions about which INR goal we wanted. And unfortunately, right before I left for PCORI, we were starting to see data that looked like this, where the valve thrombosis and thromboembolic events started to way outpace the warfarin group in the apixaban group. And we were starting to realize that we were never going to reach our non-inferiority margin. So this was a pretty big blow to us. It was a very big blow to our patients. Almost, I think about 10% of the patients we had enrolled in the trial communicated with the PI to see if they could continue the apixaban arm even after we took them off of it. So definitely was a big, big disappointment as well. Certainly affected a lot of other clinical trials that were running worldwide looking at this particular issue. Informed consent. Okay. How many of you have written an informed consent form before? This is an informed consent. 8 pages, 7 pages, including the signature page. All we're doing is ask them to fill out a survey on an iPad. Okay, so kind of annoying, necessary, but a huge turnoff if you're a patient. So remember that iPad study I was wildly crazy about? This is one where we also thought, hey, let's think about gamifying this informed consent. And so we made it into the sort of Candyland type of format here where people could kind of get excited about doing it, doing the little short spurts. There are opportunities to ask questions. Most importantly, we put this in the waiting room of a clinic. So if a clinic patient showed up, they checked in and they're sitting in the waiting room waiting to be seen by a physician, we'd hand them this. And it was done in a way so that a clinical trial coordinator didn't have to sit right next to the patient to be able to go through everything. Okay, so it was really great. It was also really wonderful because it featured some of my closest friends who were just so much more personable about explaining research than I could ever be. And also who were of very diverse backgrounds that could really help people feel like they could be part of this research project as well. Often that's a very sort of forbidding type of thing. And so it was really, really amazing. And what resulted from that is, this sort of video consent that replaced that 7-page document. Now, if you took those 7 pages and you read them, you just sort of use that as your script to go into a video, that's 28 minutes. 28 minutes of listening to a video person on video, reading an informed consent to you, I think you're about ready to be done with the trial at that point. So it took actually about 6 months for us to negotiate with an IRB. How do we condense a 7-page consent form to a 7-minute video that we then broke up into 1-minute segments so that we could, make this more digestible. So that was another thing that was really, really interesting here. What are the things that you could take out or not verbalize? But at the end of the day, by being able to do this, you could see that we were able to recruit in, we were a little bit more successful in recruiting older individuals where they, if they didn't bring their reading glasses with them, they could still be able to listen to the consent. We were able to do this and get more sort of diverse representation in our clinical trials. We were also able to get sort of patients with lower health literacy into the study. I show this curve on the bottom because I'm really, really excited. The dotted curve was sort of our plan for enrollment. The red curve is what actually happened. Now that 3-month delay, I like to thank Apple for that. We were playing with an iPad. There was an iOS change. We had to go back and redo our app to be able to meet the needs of that iOS change. So there was a 3-month delay in getting things going. However, I'm really excited in that we actually finished 2 months ahead of schedule, despite that 3-month delay, because people really enjoyed the experience of being able to do this. And in fact, the day that we were supposed to go for 7,500 patients, we stopped it the day that we were getting really close. And 1 day later, we had gotten up to 7,658. So it kind of gives you a sense for how rapidly we were able to really recruit with this. I'll end with my why. So you've probably seen me sort of talk a little bit about sort of gaps in care, how we generate evidence, how we get that out into practice. At the end of the day, what I hope for is always what we all hope for, which is equitable care and improved outcomes. And along the way, hopefully what I've showed for you is how we think about incorporating research into routine bedside practice. And I'm purposely showing you the next generation of research leaders that I've had the privilege of working with. This is partly what motivated me to transition to PCORI. For those of you who don't know, PCORI is an independent nonprofit research funder where we really are funding sort of research that fills a public need. And in particular, we're focusing on people who want to know which is the right therapy or the right decision, healthcare decision for them to make. And we fund comparative effectiveness research that really helps look at these therapies that are often already in widespread use or already have efficacy proven to help make those kinds of decisions. If you're interested in applying for PCORI funding, which I hope you all are, there are a couple of things that really distinguishes CER that we fund from CER that other funders fund. And they're listed on this slide. I wasn't kidding when we talk about patient stakeholder engagement. That is a cornerstone of every PCORI application here. And it's not just a nod towards the patients. I'll show you a little bit later what I'm talking about here. It's almost always comparing 2 or more therapies, which means placebo-controlled trials are really not something that we think about unless placebo is absolutely needed for scientific integrity here. We're really often thinking about 2 real healthcare choices out there. Pragmatic trials, real-world settings, real-world clinical processes, yes, those are pretty much what we're hoping to be able to fund. And in particular, a lot of those phase 3 trials are really looking at it from a population standpoint. What we'd also like to know is from an individual or subpopulation standpoint or subgroups, are we seeing those kinds of things translated as well? Our research, our patients are really involved from the very first step all the way to the very last step in PCORI. So peer review of a particular application that gets submitted. We almost always have at least 2 individuals who are patient representatives on these panels. And so they're very much a guide to what we do fund. They're also very much a guide to what we choose to ask for in terms of funding opportunities, and they're a guide to what we choose to disseminate afterwards as well. And as we think about and I think this is my last slide. As we think about engaging patient stakeholders into research, I think there are different ways of engaging them. When I started in my career, it was very much on the left-hand side. It was sort of seeking input. So we would ask, we would do focus groups, we would crowdsource, we would do some town halls, we would go have conversations. But as time went on in my career, and this is partly why I kind of gravitated towards PCORI, I started gravitating towards the right side of the slide where we're actually hoping for more sort of co-leadership. So I gave you the example of that AFib study that we did that was completely co-designed with our patient stakeholders, where they are also part of the leadership, where they also got a research salary or an honorarium commensurate with their efforts, where they led certain tasks associated with the research project. And I think that that's an area where probably we as a research community need to get more familiar with as we continue to approach clinical trials. Finally, we also really want to talk about returning research results to patients. Often the academic mindset will stop at publication. It's out there, people know I published this is great. Remember, keeping in mind that we're doing this for our patients, how do we get those results first and foremost to the folks that helped us get the research done? And that's one of the PCORI sort of requirements. And we're very excited to say that, over 80% of our research is being sent back to participants to inform them of sort of the fruits of their labor. This is an example of a study that leveraged their stakeholder group to create an English version and a Spanish version of their research results that they were able to return to their participants as well. So I won't go through the conclusion slide. I think I'm just going to wrap up here.